So now I'm going to introduce Omary and Natalia, our next two panelists. They'll each have the opportunity to speak for 15 minutes. I'll spend then a little time trying my best to synthesize on demand the discussion that just ensued over the last hour, and then we'll open it up for some questions with the forum and the public. So with that, I'd like to first introduce Omary Chillo. Omary is the president of the Tanzania Health Summit. He also serves as a member of the board of National Public-Private Health Forum with the role of coordinating both the public and private health institutions, reaching 52 different organizations. This includes the Tanzania Investment Center, medical store departments, etc., in order to share, discuss, create solutions for public-private engagement in the health sector. He's also worked with the Ministry of Health in a task force to engage public and private sector in advocating for prevention and control of non-communicable diseases countrywide. So welcome, Omary. And then I'd like to also introduce Natalia. Natalia Korchakova-Heeb is Managing Director of SDG 17 Consulting. She's internationally recognized as an expert in sustainable infrastructure, public procurement, public-private partnerships, international technical assistance, and has deep experience in the public-private and non-governmental sectors. She also has extensive experience in advising national governments to improve their national frameworks across various jurisdictions with people-first public-private partnerships. She's led the working group on partnerships at the Global Health Hub of Germany, and she's also a member of the Strategic Committee of the World Association of Public-Private Partnership Professionals and Public-Private Partnership Units. So with that, I'd like to welcome them both to the workshop. And Omary, you have the floor.
Good morning, everyone.
Good morning.
Well, thank you very much, Lisa and your team, for inviting me to these global meetings. And I will speak on the practical aspect of myself and the team that we are doing in supporting the private sector to be engaged with the public. So to start a little bit on the Tanzanian perspectives, in 1967, we had Arusha Declaration, which actually abandoned most of the private sector activities in the country. So we were going into socialism, more of socialism. So most of the activities actually were down. Very few people who were actually doing trading activities were allowed to do so by the private. But in terms of health sector, the government took the whole role of building the hospitals, dispensaries, and other health infrastructures, so that it was managing 100% of the health sector. But this actually changed in 1991, whereby after we had a lot of economic downturn in late 70s and 80s, so the government felt a lot of pressure because of the increase in the populations, which was not going in parallel to the investment in the health sector. So then afterwards, the private sector actually were allowed to get in to support the government. And more success stories happened in 2009 and 2010, where we had all these kind of documentations, strategic plans, and the policy built up so that to support more in terms of documentation of the health sector. So, as I said before, I'm going to speak more on the models that actually we're working with my colleagues to support the private sector. So you can see this is a typical hospital on your left side, where we have long queues, women waiting for the service for the children, immunization programs. Well, I say we are a lot behind in comparison to the health sector in most of the countries, and especially when we comes to communicable diseases and non-communicable diseases. The first thing that we usually do with my colleagues in the forums, we sit down with the government of Tanzania and we discuss on the essential gaps that actually they take us back and not to achieve the universal health coverage. So one of the areas that we are more discussed one was on supply chains. Initially, the government is a big role in supply chain using its medical store departments, which is main role is procurement, storage, as well as supply. But it serves less than 30 million people, and the country is more than 55 million people now. So the rest of the population, actually, we are not included into the national medical supply. And this is amount of more than 80% of procurement is actually done from overseas. This is another challenge that the country buy a lot of medicine from outside. And India is leading, and USA is the fourth supply of medicine in the country at the moment. So the MSCD supply only 60% to the health facility. So where does 40% come from? This is what we look into the gap of the 40%, how we're going to fill this one. And a lot of discussion were going on in terms of supporting the 40%, which will involve the private sector. And here we have, we identified the number of private sectors, which are actually 400 suppliers of medicine in the country. And also the value for importation is more than 900 million USD. And this sector supplies more of private sector, and especially also with the NGOs, which they can buy directly. And also the number of manufacturers in the country is only 6, and only one is actually GMP certified. So you can see the difficultness of having medicine in the country. And in this case also, the manufacturers only can make 10% of what the country is required, but also only 10 lines. I mean, the manufacturer lines only 10, and we need more than 80 ones. So we involve a system which is called prime vendor system, and this was an engagement with a local NGO to see how best we can support the 40%. And we put like a prime area, small area, which we can see the progress afterwards. We can expand it. So what we did, the amount of money actually the health sector, the health facilities actually are receiving from the patient were used to buy medicines from the private sector. So the government provides 60%, but the 40% people who are contributing from the insurances, but also out of pocket, they used to buy from the private sector. But the challenge also came back that we had a lot of bureaucracy on buying these medicines. And this is because of the different kind of the prices from different from the different vendors. So we choose one vendor, what we called the prime vendor. So the prime vendor is a person who actually recognized by the public sector, but he's responsible to be able to get contact with the other small private sector, whereby all the medicines which are needed from the government sector, they can be supplied at one point. So the prime vendor is responsible to make sure that whatever is missing from the government can be available at the moment. And that's why it was very effective. And when it comes to the output of this system was the medical availability from for the public sector rose from 61% to 95% just within 5 years. And this also corresponds to decrease in delivery time. We initially had more than 1 month. If you apply for medicine from the medical store department, it can take even 1 month. But now, just within 10 days, you already have something substantial for the health sector. But also, the purchase value to the private sector increased. So there's a lot of engagement from the private sector in terms of also generating income from the government. performance was also very, very increased, but also order fulfillment. So in this moment that we have a lot of availability of medicine into the public sector. So this one was most successful model for the private sector engagement. Again, in 2011, 2012, we, together with other colleagues, we also discussed on the service level agreement. We had a lot of hospital, for example, in the country we had more than 700 health facilities, but we almost have half percent of the hospital which are actually required. And most of these hospitals are coming from faith-based organizations. You can see the figure there, the hospital from faith-based organizations is almost double, is almost the same as the government. That means you have almost the same number of hospitals. But also the private sector contributes significantly by 66 hospitals in the country. So in these faith-based organizations, hospitals, they are mainly located into remote areas in hard-to-reach places. And so what we did with the colleagues was to make sure that also people who are in the poor area, they can get services as the same as the one which are in towns. In this case, so the government decided to support the hospitals which were not initially from the public sector. So in this case, the funding actually, the government provide fund to these organizations, and this is more than 60% of the funding actually from the government to support, especially paying for the health. For paying for the human resource for health, but also to support on the information system. The system that is produced within the private sector can also be connected with the government, so that the patient can be easily referred, and you have interconnected information from different regions of the country. So not only the human support for the funding, but also faith-based organization, the private sector contribute a lot in terms of learning institutions, health learning institutions. So you can see more than 7 health learning institutions are coming from the private sector. In addition to that, we also involved them into promoting healthcare and prevention activities, including non-communicable diseases. So the private for-profit is not really engaged so far because of a lot of the government bureaucracy and trust behind it. There are more of supplying medical equipment, but also we have a number of private institutions which also are funded by the government to teach medical students. So the loans actually coming from the government, but these have to be paid back to the public sector. The third one, health insurance. This is the biggest problem in Tanzania, and less than 30% of people in Tanzania are actually health insured. The rest of the majority are not insured. And most of these who are not insured are in the informal sector. So there's a lot of challenges on how to engage the informal sector to be also health insured. And a lot of schemes have been developed to support the informal sector, but also the poor. For example, the CHF scheme, the Community Health Fund scheme, it's actually a very small amount of money that someone has to contribute. It's less than $5 per year. So, but it also support a lot of patients in the community. So, it's basically supporting basic health services, like if you have malaria, but does not cover the major costs involved with health care. So the National Health Insurance Fund is the major health organization in the country, which takes more than 20% of the population support. And you have also the private sector, which is about 2 to 5%. So the major question was how to involve the private sector to support this. So we had a lot of, we use sometimes mobile applications to support people contributing in a monthly basis to the health schemes. And this has been worked for few people, but it's not very well taking over. We are looking into a way that it can be scaled up to the villages and remote areas. It's more applying to the towns where people they have access to mobile phones. But also the National Health Insurance provide loans to the private sector. And up to this moment, it's more than $7 million USD. The other one, which is more engaging the non-government organizations, health system strengthening. We had a lot of projects going on to make sure that the government going transparent, but also more realistic budgets are made through these programs, which actually improve the capacity of the health facilities, but also the management of health facilities make more and more important. I would like to end that, and I thank you very much for again inviting me. And this is our city, it's Dar es Salaam by night, so you're welcome. Nice beaches, but also Tanzania is the land for Ngorongoro safaris. Yeah. Thank you very much.